Hello and welcome to Women's Health. My name is Kathie Uhrmacher. I currently serve as the chair of the Mayor's Commission on Women. And on behalf of the Commission and also the Women's Foundation, which is providing funding for today's program, welcome. Today we're going to be discussing some very important research related to infertility. I'm joined today by my co-host, Lyndie Christensen Nadar. Lyndie is a member of a commission and also a doctoral student in the College of Psychology. So this is very exciting at the University of Nebraska. And our guest today is Dr. Julia McQuillan. Dr. McQuillan is the chair of the Sociology department at the University of Nebraska. And she is also here to tell us about this important research. So I'm going to ask you just to give us a brief idea about what your research is, the main idea of it, and then we'll get into some discussion about infertility.
Thank you. Thank you, Kathie. I really appreciate this opportunity. So basically our idea was to try to find out what are the barriers to women who have infertility getting help, and what are the consequences of infertility. All the research before our study had focused on women who either had already received help or were large national representative samples that didn't have outcomes such as distress or life satisfaction. So we wanted to kind of fill that gap and really understand women's experience of wanting children, not being able to have them, what the barriers are to treatment, and also women who have various paths. So if they adopt or decide to be child-free, what their life experiences are, because very few people knew about them. So we got funding from the National Institute of Health, their Institute of Child Health and Development. I had collaborators Lynn White and David Johnson at the University of Nebraska.
Okay, great. Let's just start out with some basic information about infertility. I think that lots of people, when they hear infertility, immediately think it's a women's issue, it's the women's fault, if we can say that it's mostly a middle class, white American sort of problem. Can you give us a little bit of a definition about that and maybe some idea of the statistics involved?
Sure. A lot of people don't realize that there's a very simple definition for infertility. It's 12 months of unprotected heterosexual intercourse without conception. So it's a very simple definition that belies a lot of complex factors that can contribute to infertility. The research suggests that 30 to 40% of the time it's the woman's factor that's contributing to infertility.
So in other words, a physical issue on the part of the woman.
Right.
Okay. So
And
only 30 to 40%.
Right.
Okay.
Another 30 to 40% could be something having to do with the man. So the woman, it might be polycystic ovarian syndrome, blocked tubes, failure to ovulate. There's a variety of things that could be causing a problem with conception. For men, another 30 to 40% of the time, it's male factor. So it could be low sperm count, low sperm motility, a variety of factors that could influence male factor infertility. And then another 20% could be something about the combination of the couple. So it could be that the woman's body is allergic to the male sperm and actually killing it. So there's a variety of factors that can contribute, or they just don't know. They can't figure it out. Oftentimes they'll start to treat even before they know, because some of the basic problems can be taken care of by that.
So it's not just a women's issue. And
it's not just a white woman's issue. What happens is most of the time in the media or in clinics, we tend to see white middle-class women, they can afford treatment. Actually, and also we think of it as involuntary childlessness, but many women have infertility after they've had a pregnancy. So they may have, as a teenager, had an unintended pregnancy, not kept the pregnancy, or given it for adoption, and then later find out they have infertility, or they've had a child, want a second child, desperately want a second child, and then find out that either complications from their first pregnancy, sexually transmitted diseases, something else could influence their ability to have another child. So many women and couples have secondary infertility, and also more Black and Hispanic women have infertility than white women, proportionate to the representation of the population. So
very interesting.
And also Africa has a whole infertility belt. So we think of it as being American, but it's actually really global.
Really. Yeah. So in other words, it's a very simple definition, but a very complex problem. And I'm sure in your research, that's one of the many aspects that came out, is the real complexity of the situation.
Exactly. For example, I've talked about infertility, but we can also think about involuntary childlessness as being broader in terms of fertility barriers. So women and men who can't find a partner to have a child with. Well, they want to have a child, can't find someone to have a child with. They have a fertility barrier, but it's not what we think of as infertility. So there can be a broader notion, or having sterilization at some point in your life and then later wanting a child, maybe with a new relationship, a new partner, or having back trouble. We don't think of back trouble as being a fertility barrier, but if your doctor says you really shouldn't carry a child, that's not something we think of as infertility, but in effect, you can't have a desired child. So it's really complicated.
So outside of different physical types of barriers, are there different kinds of social barriers that can be considered fertility barriers within your research?
Absolutely. So one of them would be not having a partner that that either wants to have a child or that you feel like you can have a child with, or just not having a partner. Another would be feeling like you can't afford a child. We all know with the Great Recession, a lot of people are really struggling with figuring out, if I want to raise a child the way that I hope to, and that can I do that with my financial situation? Or can I combine a child with 3 jobs? Both my husband and I, or my partner and I, are trying to just pay the rent and eat on what we have. Can we afford, or I'm still living in my parents' house, can I afford to have a child? So it's really complicated. Maybe I'm still paying student loan debts or whatever. So a lot of people are really struggling with that combination. So, and then some kinds of jobs just make it really hard. So there's a variety of social structural factors, and those affect some people more than other people as well. So that makes it really challenging.
In your research, did you find that women who do not have children, then they say they don't care, they do care? Is it eventually I give up? Is the age at which a woman chooses to have a baby, is that also an issue?
That's a really good question. So another social barrier could be that if you delay, so you say, well, I want to finish school, and it's hard to have a baby in school. There's no daycares in the dorms. And I have a job, and it's really, I want to give everything to that job and get as far as I can before I have a child. Well, by the time you're 30, your fertility starts to decline. So if those social expectations that we first have education, then we have a good job, then maybe we settle down, by the time women have a biological clock. And so by the time you're over 30, it becomes more difficult. And I don't want to scare people and say, I should go ahead and get pregnant necessarily right away, but it is something to consider. Many people don't plan also. So there is at least 24% of American women who say, well, I'm going to see what happens. So there's a variety of pathways to that, but the mismatch of our social patterns and biological clocks can be a real problem in the United States.
And that seems to be a real issue in the United States.
It is. And then after 30, it gets more difficult. After 35, there's a real drop-off in fertility with aging eggs, and it just becomes a lot harder. So it doesn't mean you can't, but it becomes more difficult. And if women don't realize that, I think it's about 80% of women get pregnant within a year of unprotected intercourse. So there's probably something to look at. If you've gone a year, they might wait another year or another year and not realize that if they went to get treatment earlier, they might have a better outcome. Now, not everybody wants treatment. As you said, some people say, well, wow, I have a barrier. Maybe I should get a dog instead. Maybe I should travel. Maybe I could do volunteer work. Maybe I want to be a really great aunt or be involved with my kids of my friends. There's a variety of pathways. Very few people in their teens think, I never want to have kids. That tends to be something people drift into because it's such a strong norm in our society, especially for women, that they will have children. So sometimes that will evolve, and then it's not a barrier anymore. Then it's just, okay, this is a different path for me. And the increase in the percentage of women who are ending their reproductive years without ever having children has increased from 10% to 20% in the last 40 years.
Is that right?
Yes. So
that's quite significant.
It's very significant. So there's more, now some of those women, about 10% of those women, it's not voluntary. So they've had a barrier. Some of them may make peace with that, some of them may not. Some women who are in their 70s who never had children and wanted them, they make peace with it, but then when their friends start bringing out pictures of their grandchildren, it can be a real problem again. Other women are fine. So there's real variation.
Many studies about infertility, they come from clinical samples or from other national surveys. They maybe aren't focusing on distress as frequently, and so that was something that was a key part of your research. So what did you find in terms of distress for involuntarily childless women or voluntarily childless women?
What we found is that in terms of strictly infertility, not all women have elevated distress compared to women who don't have infertility. It's really the involuntary childless. So if women have secondary infertility or if they weren't trying to get pregnant when they had that 12 months of unprotected intercourse, then they tend to not have any distress that's different than the general population of women who have children they wanted. But for the women who have involuntary childlessness, they have elevated distress. Mm-hmm. It has to be the biomedical barrier, though. Women who have the social, what we call the situational barriers, they tend to not have different levels of distress from women who didn't want children or are delaying. So it's actually a much more complicated picture than the simple picture of desperately seeking. Yeah. There's a variety of responses, and I think some women who find out they have infertility and decide not to pursue treatment may feel a little funny about that because the media images are of women doing anything they can. Mm-hmm. But really it's quite expensive to pursue biomedical treatments, mm-hmm. and adoption can be quite expensive too. So I think it's important to know there's a variety of responses, and that's okay. And a lot of women find that they can do other things with their lives. The ones that do really want to have a biological child, it is very hard. The ones that have that they do have elevated distress.
And what part did you find that religion plays in all of this? People obviously have different feelings related to childbearing because of religion. So what did you find about that?
So we were really interested in this. One of my colleagues is an expert in religion, mm-hmm. so he was particularly interested in this. He had a paper early on that was about sort of why is God doing this to me for women who have infertility? So we were looking at this, and initially we found there was no association. We wanted to know if women who were more or less religious would be more or less likely to seek treatment. And he found nothing. And then we thought about it some more, and he said, well, maybe women who are more religious have more ethical concerns about treatment. There's a variety of possible ethical concerns. So we looked at that, and we found indeed they did. So it was the women who had more ethical concerns, who are more religious, have more ethical concerns, so they were less likely to seek treatment. Mm-hmm. But then we also thought, but wait a minute, more religious women are probably more likely to have more importance of motherhood in their lives. Mm-hmm. So maybe they'd be more likely to seek treatment. And we found indeed that both pathways can operate. So it just sort of depends upon which way your religiosity takes you. Mm-hmm. It looks like no association initially, but it's really through these internalization of either importance of motherhood or ethical concerns. And there can be a real tension within individual women about I really want to be a mother, it's a really important part of my faith and my religious path, but I'm really concerned about a biomedical path. So maybe some of those women might pick another path, such as adopting, fostering.
Right. Well, this is just fascinating. I want to thank Lyndie for being here today. Thank you, Lyndie, our co-host today. And especially want to thank Dr. McQuillan. Thank you so much. This is such a fascinating topic and one that is very important, and I think it would take a long time to be able to talk through everything. So we really appreciate your being here. And thank you for joining us. This is Women's Health, the program that is by women, about women, and women's health issues. Today's program was sponsored by the Women's Foundation, and if you would like to know more about the Women's Foundation, and also if you would like to see other women's health programs, please go to our website, lincolnwomen.org. And if you have questions or comments or concerns, things that you would like to have us talk about, please go to lincolnwomen@gmail.com and send us an email. We really would appreciate hearing from you. Again, Kathie Uhrmacher, and thank you today for joining us at Women's Health.